what is virtual reality? So is there like an echo, or is this okay? Is this okay? Okay. So virtual reality is a three-dimensional computer-generated environment in which a user interacts with a graphical character representative called an avatar. So, virtual reality is very popular right now, but it's not something that's new. It's been used in other fields for quite some time. So, for instance, in aviation, it's been used for decades. It's been used in surgical training and has actually been shown to improve trainee laparoscopic procedures. So there are some clear advantages you can probably just think about with avatar-mediated or training using virtual reality. So with this type of training, you can take a learner into multiple settings during a single session. You can conduct it wherever you want, and then you can really standardize the experience for learners. So when we were thinking about what is the best educational strategy that we can use to teach our learners how to communicate with families about the flu shot, I work in a primary care clinic mostly in Cincinnati. We, like a lot of other places, are extremely busy. So ideally, I would be in the room and directly observe a learner counseling a vaccine-hesitant family and then provide some meaningful feedback afterwards. However, it's not really possible. So we thought that virtual reality might be a nice method to give our learners an opportunity to practice these communication skills. So our hypotheses were that residents would find the virtual reality experience as effective or more effective than traditional medical education methods, and also that influenza vaccine refusal rates would decrease in our intervention group that underwent our virtual reality curriculum during our post-curriculum period when compared to our control group that did not. So we clearly identified our problem here. So for our needs assessment, we first did a literature review and conducted a focus group that included providers and staff members at our primary care clinic. What we were trying to identify were common reasons for vaccine refusal. What we found is that many of our families felt the flu shot was ineffective, that it might cause injury, or had some misinformation regarding contraindications. We were also interested in residents' experiences with counseling on the flu shot. So what we found was that residents were frequently experiencing hesitation in clinic, and in most cases of vaccine hesitancy, they were not able to persuade a family. So we asked residents, how frequently were you able to persuade families who were initially hesitant about the flu shot to get their child immunized? You can see here that the majority were unable to accomplish that task. So the next step was actually developing our virtual clinic space. So in order to make this experience as immersive as possible, we really wanted to replicate an actual clinic room at our primary care center. So you can see here on the left, we have our virtual clinic, or our actual clinic, and then on the right, we have our virtual clinic. We created 4 avatars based on common caregiver demographics seen in our clinic. Avatars were able to assume 4 different body positions to express the emotions of anger, disinterest, neutrality, and interest. We also documented common phrases that families use during vaccine counseling, and we recorded that audio. We synchronized it with the avatar's mouth movements and facial expressions so that the avatar could interact real time with the learner. The curriculum consisted of 3 simulations, each one focusing on a different reason for influenza vaccine refusal. In order for a learner to get vaccine acceptance, they had to demonstrate a number of best practice communication skills. This included things like asking open-ended questions, being empathetic in your counseling, and providing medical education to families without a lot of medical jargon. I'll pull up a quick video here. Just to give you a quick, so this is just a view. So we use the Oculus Rift to deliver this education. And you can see here that we tried to create a fully immersive environment so the learner could look in any direction and they would feel like they were in the clinic space. Again, we wanted to replicate an actual clinic room, so the placement of the computer, the examination table, even all the art on the walls are taken from our actual clinic space. So during the simulations, there was a facilitator who real-time could adjust the avatar's nonverbal and verbal language so they would respond appropriately to the learner. Following the 3 simulations, we would give feedback to the learner about his or her use of best practice communication skills. So in terms of our study design, we targeted senior categorical pediatric residents who had their continuity clinic at our primary care center. Residents were randomized by a previously assigned continuity clinic day to either our intervention and control group. So all residents underwent our standard education regarding vaccine refusals. This includes a short PowerPoint slide prior to the start of clinic. However, only residents who are in our intervention group actually underwent the virtual reality curriculum. So we ended up with 21 in our control and 24 in our intervention group, and the education took place in November 2015. We then collected patient data for the subsequent 3 months to look at rates of vaccine refusal. In terms of evaluation metrics, we were interested in residents' attitudes towards this type of education, so we collected that with written comments and semi-structured interviews immediately following the simulations. We were also interested in how residents perceived virtual reality compared to other educational strategies in terms of its effectiveness. So we asked about things such as reading or traditional didactic teaching, such as a PowerPoint slide, online learning, standardized patient encounters, high-fidelity mannequins, and bedside teaching. And we tested for differences here using a multinomial exact test for equal proportions. Our primary outcome was actual rate of influenza vaccine refusal. So eligible encounters included patients aged 6 to 59 months who were presenting for well child care. That was sort of the background for each of the simulations. And then we looked at the binary outcome of acceptance or refusal using a logistical regression model. We also performed a sensitivity analysis to incorporate a random effect term for a resident provider to check for nesting within providers. In terms of our results, from a demographic standpoint, we had no significant differences between our intervention and control group in terms of age, sex, race, year of residency, as well as perceived frequency of influenza vaccine hesitancy during the previous year. In terms of attitudes, 92% of residents agreed or strongly agreed that the interaction was similar to real-life experiences. Qualitatively, residents felt the experience was immersive, that it was realistic and fun. So here are just a couple of quotes from some of our learners. They thought it was really cool. They felt like they were in the office. They felt the scenarios were very realistic, as were the patient responses. So as I mentioned, we also asked how residents perceived this compared in terms of its effectiveness to other traditional educational strategies they might have seen in medicine. The residents felt that the virtual reality experience was more effective than reading, didactic teaching, and online learning. They thought it was equally effective to standardized patients and high-fidelity mannequins, and they thought it was less effective than bedside teaching. So as I mentioned, our primary outcome measure here was actually rates of vaccine refusal. So, 5 minutes. So in order to accurately capture vaccine refusal, we embedded a best practice alert within our electronic medical record. We then trained residents to use that alert in order to document true refusal. The reason we did this is because we wanted to differentiate between vaccine refusal and more of a missed opportunity. So, a missed opportunity would be a patient who was eligible for the flu shot who came to clinic but didn't receive the flu shot, maybe because a provider forgot to ask about it. So by using this process, we minimized the number of charts we actually had to review to look for documentation of refusal, and we're able to capture 95% of the eligible encounters during our study period. Here are the results in terms of rates of vaccine refusal. So here on the y-axis, you can see the rate of influenza vaccine refusal. On the x-axis, we have time. You can see in our pre-curriculum period in September and October, the rates between our control group, which is in blue, and our intervention group, which is in green, were pretty similar. They were actually exactly the same in October. We implemented our virtual reality education in November. You can see in the month immediately following that, there was about a 15% difference between our groups, and there was at least a 10% difference maintained throughout the study period. These results did end up being statistically significant, which surprised us given our small sample size. And when we performed a sensitivity analysis assessing for nesting within providers, we found similar results. Our study did have some limitations, so it had a small sample size. This was conducted at a single site, which might limit its generalizability. Also, we didn't directly observe residents during clinical encounters to see if they were using the best practice communication skills they learned during the simulations. we used vaccine acceptance as a surrogate for curriculum uptake. In terms of conclusions, residents reported that virtual reality training felt immersive, realistic, and was as effective as standardized patient encounters. Training resulted in a statistically significant decreased rate of vaccine refusal. So overall, we feel that virtual reality experiences such as this curriculum might be an effective approach when educating providers on communication strategies, especially when it comes to difficult topics such as vaccine refusal. So this was really a collaborative effort between physicians, educators, technologists. I just want to point out Melissa Klein here, who's my primary mentor, and then Daniel McClendon, who's here in the room. He's one of the educational experts on the team. I'll open it up for questions and comments. Yeah. No. Mm-hmm. Mm-hmm. Right. 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 Yeah, I think that's a great, yeah, it's a great question because I think, if there's one little odd thing that's in the simulation, that's going to throw it off, right? Because it's no longer going to feel immersive. So we spent a lot of time piloting this, and I actually facilitated every session for this. So I trained myself quite a bit that I would respond very quickly to patient comments and, change their body language in such a way that it felt natural. So when I did the semi-structured interviews following it, no one commented that they felt that there were glitches or there were certain details of it that weren't an accurate representation that distracted them from the simulation. I think overall the feedback was they felt that it was really immersive. They felt like they were in a clinic room. But I think that was probably secondary to a lot of piloting that we did and iterative modeling of it so that we could create something that really felt realistic. Mm-hmm. Yeah, so I think that's, a great question. Standardized patients can be pretty expensive. So there's some expense, obviously, with this, an upfront cost of developing it. However, we're now changing the scenario so that we can do multiple scenarios. And once we sort of have this product, we can reuse it. So we asked residents, what other situations they use the skills they learned in this, and they talked about, obesity counseling or counseling for other vaccines. We're also going to try and adjust this scenario to help residents practice communicating about the social determinants of health, so things like maternal depression or food insecurity or homelessness. So our thought is that the benefits of this are you can do it anywhere, you can do it at a time and place that's convenient for the learner, you can take them into multiple settings, you can assess them by having it standardized. There's obviously variability that accompanies standardized patients, which you can avoid by using something like this. And then we think long-term, this will probably be more cost-effective, especially as the cost of something like the Oculus Rift has come down quite a bit even over the last 2 years. Yeah, so I think a lot of our medical students and residents are all within that sort of millennial generation of learners, right? So they're interested in technology and real life experiences and timely feedback. So we targeted senior residents because, we felt like when we were looking at the clinical outcome, flu acceptance or refusal, it's the resident that's typically having that conversation. And we wanted senior residents because we felt like that year of experience was important to kind of develop your own personal skills. But I agree. I've done this we haven't studied it, but I've done it with medical students, and they've really enjoyed it. One other project we're working on now is using a virtual environment to teach physical exam skills, especially respiratory distress in patients with bronchiolitis, because I think a lot of times medical students can get kind of pushed to the side, especially if a patient's getting sick, but those are extremely important skills for them to learn. So we're targeting medical students with that, so we'll be curious to see what their attitudes about this educational strategy are as well. So for the feedback, it was conducted immediately following the simulations. We had a standardized checklist, which would document sort of their use of the 3 main best practice communication skills that we were looking for. During our initial sort of the study that we did all the feedback kind of at the end after they had done all 3 simulations, which we felt was less helpful than doing it after each one, so they could then practice those things that maybe they weren't so good at. So when we did it again this year, we did feedback after each simulation so that they could then use those skills in the next one.